Could we have the discussion slide, please? And the presentation is open for discussion. So the proposal that you're making raises obviously controversy, because you could argue that once you have rehabilitated a patient, implanted with an LVAD, the argument is that they're in good condition. You should perhaps allow them to undergo some priority in having a donor heart. But by doing so, doesn't mean that even more patients who are with heart failure waiting for a heart transplant will end up on a VAD. So we end up doing bridging for every patient who eventually needs a heart transplant.
Excuse me, what is your question?
My question is, if we allow some prioritization.
Is it USA or Germany?
In Germany.
In Germany, okay.
Or any system.
Because allocation system is different in any country.
Yes, but what you're proposing is that you reduce, or you have a finite blackout period, and then after that you allow some priority for patients who are stable on VAD to have a heart transplant. Is that right?
Yes, our proposal is survive long enough with VAD. Some patients become psychiatry sick, for example, depression, because the length is infinite length. That's sentenced. One complication occurs, then there's a chance. That's not good. Then give a little chance to transplant these patients.
Yes, I understand. Let's say we can be arbitrary about the length of time. Let's say 6 months or 1 year of support. So when they've survived the 1 year of support and they're stable, are you proposing that after that period they should be allowed to have some priority for a heart transplant before they develop other complications?
You mean or I mean? Yes.
Is that what you're proposing?
Proposing, because this blackout period is, I have presented, the German Physician Association decided with VAD no priority for urgent heart transplantation.
Yeah. So assuming that's accepted by Eurotransplant or it's accepted in Germany, that you allow patients who are stable on a VAD long term to have priority over a heart failure patient on the waiting list, does it not mean that even more hearts will go to patients who've already got a VAD, and then a higher proportion of patients who are waiting for a elective heart transplant will end up needing bridging with a VAD?
I cannot understand your question. This is.
You want to say? Aska?
I would like to add a few words to the same sort of question there. I think that inevitably we are going to get into that sort of situation because obviously demand is more than the supply. When we look at the results of the bad patients, actually the younger patients get the most benefit possibly, because we have seen the review of this in the UK as well. So if younger patients ended up having VADs, then they are going to get transplantation. As long as the results of the transplantation are no inferior to those who are not on device, then I think we are going to see this happening more and more, than many patients who are going to have transplantation are from those group who already had a device. And it's just the way the practice is.
So are you actually claiming that you should put an age cutoff limit?
No, I don't think that it is, but when you look at the practice, that is usually the case. The more younger people actually end up having devices, we try to rescue more moribund young patients which actually they get the most benefit from that because they are such a they are at high risk. So it is automatically, I think, is getting a bit adjusted that way.
No, but Aska, the question, I mean, the topic we're discussing is once the patients have received a VAD at a certain time into the distant future, are we going to give them a priority on the allocation system?
The situation is going to actually get in a bit. If you look at some of the big centers in the UK now, 90% of those patients are on the device actually. And the priority then comes, so every patient is on the device, so you don't have to...
No, the question is whether they should be given priority when they're stable, well, or only after they develop a complication from having a VAD in place.
I think that's a very difficult question.
So it's at the moment it's not acceptable that the VAD patient should stay in hospital for several months to get an heart. So it's sure we should change something. But the problem still in Eurotransplant is we have not enough organs. And that's the reason why my chief is working on that, and we should change something. We need more organ donor in Eurotransplant. And we start with a big publicity in our country, in Germany, to change something, to get more donor. And I think the good idea is what they have in Austria. So we need a change in donors, and that is on where we should work on. Thank you.
Thank you.
So actually, the best option would be to be able to remove the VAD rather than to transplant our patient, and this gives me the opportunity to call Aska to the podium to deliver his lecture. That is how to decode the assist device. Thank you, Dr. Komoda.
Thank you very much, Chairman and ladies and gentlemen. I wish we develop a device that we don't have to take them out. Anyway, not the surgeons.